The different types of urinary incontinence have different causes. Stress urinary incontinence can be caused by urethral hypermobility or intrinsic sphincter deficiency. In case of urethral hypermobility, the urethra and bladder neck are not supported sufficiently by the pelvic floor muscles and vaginal connective tissue. When the intra-abdominal pressure increases, for example when coughing or during exercise, urethra and bladder neck are not completely closed. Insufficient urethral support may be related to loss of strength and coordination of pelvic muscles or trauma, for example due to vaginal delivery. In case of intrinsic sphincter deficiency, there is a loss of muscular tone that normally keeps the urethra closed, due to damage to muscles or nerves, seen in women who have had pelvic surgeries. Urgency incontinence often results from abnormal contractions of the muscles of the urinary bladder, also known as the detrusor muscle, during bladder filling. The cause for this is often unknown, but it can result from neurologic disorders or bladder abnormalities. Overflow incontinence is caused by underactivity of the detrusor muscle or obstruction of the bladder outlet. In case of detrusor underactivity, the bladder cannot contract properly when voiding. This can be caused by impaired contractility of the detrusor muscle or impaired sensory function. Bladder outlet obstruction is generally caused by external compression of the urethra. This can occur with fibroids that obstruct the urethra, advanced pelvic organ prolapse, or overcorrection or compression of the urethra due to pelvic floor surgery. Less common causes are tumors at the bladder outlet or cervix. There are various risk factors associated with urinary incontinence. With age, the prevalence and severity increase. In stress urinary incontinence, obesity is a strong risk factor. Weight reduction significantly improves symptoms. Activities such as jumping and running and parity are other risk factors for stress urinary incontinence. The risk of urgency incontinence may be higher in patients with a family history. An impaired functional status, recurrent urinary tract infections, and bladder symptoms in childhood are other risk factors for urgency incontinence. Other risk factors are smoking, caffeine and alcohol intake, medications, constipation, diabetes, vulvovaginal atrophy, pelvic floor surgery, and radiation. The evaluation of urinary incontinence should be focused on the identification of the type of incontinence, which is important because it determines the preferred type of treatment. In addition, underlying conditions and potentially reversible causes should be identified. The evaluation starts with a medical history and anamnesis. The obstetric and gynecological history should be obtained, as well as use of medications. It is important to ask questions that help the identification of type of incontinence, such as time and setting of urine loss, frequency, severity, and amount. A pelvic examination is performed to observe pelvic floor muscle function, vaginal atrophy, pelvic masses, and pelvic organ prolapse. Voiding diaries are helpful to determine if urinary incontinence is associated with high fluid intake, to follow symptoms over time, to determine the maximum bladder capacity and the interval between voids. Urine analysis should be performed in all patients and followed by urine culture if a urinary tract infection is present. In patients with suspected stress urinary incontinence, the bladder stress test can be performed to confirm the diagnosis. The patient is asked to cough and the clinician observes if there is leakage from the urethra. Urodynamic testing provides information on bladder sphincter and urethral function. Although it can be helpful when evaluating treatment options, urodynamic testing does not predict or improve outcomes of treatment. Therefore, urodynamic testing should not be performed routinely in all patients. Determination of the post-void residual urine provides information on bladder emptying. In general, a PVR of less than 1/3 of the total voided volume is considered adequate emptying. A pad test can be used to quantify urinary incontinence. Patients use a pad which collects all urine that is lost over a certain amount of time, which can subsequently be measured.